So now we have some time for questions. If the speakers could please come to the podium.
Excellent conferences. I just wanted to comment. I work with sexually abused children, and I'm kind of concerned that we have this gap age in the vaccine where there'll be kids that are don't get the vaccine, they can be exposed. Do you have any comments on this?
Well, I don't know if some of the speakers would like to comment on this.
Yeah. I think it's a difficult question, and vaccination makes sense from a public health perspective. And what we have to balance now is that we don't know yet exactly how long the protection from the vaccine is. And so what we're trying to get is everyone vaccinated before they're sexually active, while making sure that they have a good protection when most would likely be infected. So I unfortunately don't think it will be possible to vaccinate everyone before they're sexually abused, because if they're sexually abused at 1 or 2 or 3 year old, it would mean vaccinating a population of newborns just in case someone gets sexually abused. But then we might run the risk that by the time they're sexually active at 14, 15, or 20, that we're not at the peak of efficacy of the vaccine. So it is a very sad situation, but in order to protect the few that are sexually abused, we would unprotect all of those who are not. So I don't know if others have something to add.
Well, I think I would like to comment on this because this is a question that has been considered as many years ago, not especially oriented to sexual abuse in children, but it has been proposed as one of the best potential ways to reach high coverage in developing countries in which there is very limited experience in reaching adolescents, and especially reaching high coverage with 3 doses. So this has been proposed to the pharmaceutical companies to do some trials in younger children, but I don't know why this has not been really taken on until recently. There is again more interest, and there are, I understand, some plans to do this in some developing countries, in some African countries.
Thank you.
Any other question?
Well, thank you very much. I wanted to ask you a question about anal cancer and prevention. So do you know, I may have missed that when you were speaking, but data on the impact of VIA in MSM for the prevention of anal cancer?
So I think you're asking about the data, whether we have data on the impact of treatment of AIN to prevent anal cancer. Actually, that was one of the last points I was making as one of the things that we don't have. So nobody has yet done a randomized controlled trial to see whether reduction or whether treatment of high-grade disease leads to the reduction of anal cancer. We are actually hoping to do such a trial, but there are no data at this point to prove it.
Any other question? Marc, you were mentioning that one of the questions that still remains is what to do with the long-term surveillance of women treated for high-grade lesions, HPV test alone or co-testing. Indicates that there is still no consensus. Could you expand on that?
Yeah, in our meta-analysis, we found that co-testing is not more sensitive than HPV testing alone. Also looked for that in that Dutch study, and also there is no difference. Nevertheless, we see that clinicians and committees that have defined guidelines, recent updated guidelines, they, without any exception, they propose co-testing. And this is, for safety reasons, the 3 or 5% that could be missed by a single HPV test are considered as worthwhile doing the expense of adding cytology. We can provide the evidence, we can communicate the absolute risks associated with the negative and with the positive test, but it's up to the clinicians who are dealing with patients to define the guidelines. And we see here that, the recommendations are on the safe side. We are, of course, here in a high-risk population where safety is much more important, where sensitivity and negative predictive value are much more important than in screening. So I can live with that recommendation. I do not have problems. But we have here an epidemiologist who is also at the same time clinician. It would be interesting to hear her opinion.
So I just want to say that we are getting this data. If some of you are interested, we have a poster, and we've randomized 2,000 women with high-grade lesions undergoing LEAP, and half of them are getting only HPV testing and nothing else. And if it's negative, they're only seen 6 months after for a diagnostic colposcopy. And so we've almost completed recruitment. We need 200 more, and we already have 2,000, and follow-up is ongoing. But I can say that up to now, the data proves what you've been saying, and we're not missing much. And I don't think we're missing any by doing HPV testing only. And what's interesting is that we recruited across Canada, so both physicians and patients were comfortable in foregoing cytology, so that they're only getting HPV testing. So we'll get there. Okay, thank you very much. I guess that Tom has some closing remarks.
I'll make a comment on that. You know, in 2006, the ASCCP guidelines made the recommendation that post-treatment for SAN2-3 that you could do two PAPs or a PAP and a colposcopy twice, or an HPV test at no sooner than 6 months. And if the HPV test was negative, you could go to routine annual screening for 20 years, which I think the guidelines are going to be changing this year. I think that they're going to move away, but we're not free to say what the recommendation will be in March, because it's under wraps until then. But I think the proposal was to go from two negative HPV tests to go to then routine screening, which would be, you know, up to 5-year screening with co-tests. But this is, in other words, there has been attempts to move to an HPV screening post-treatment scenario in the last few years, but I don't think U.S. clinicians have adopted it.
But I think that we always have to remember, when we're talking about follow-up of treated women, there are two different problems. One of them is treatment that wasn't effective, and so we're trying to find persistent disease. But even if treatment was effective, once a woman has had CIS, we've somehow identified women who are more sensitive to the effect of HPV. So most women who get HPV will clear it, won't have any abnormal cytology, no nothing. Mm-hmm. So these women, for some reason, have persistent infection and go on to CIS. So if ever they cross path with an HPV again, they're more likely to progress. And so when we follow them for 20 years, if you find a high-grade lesion after 15 years, I can't believe it's inadequate treatment from 15 years ago. That doesn't make sense. It's probably that we're seeing this group of women that is at risk, and that's why they need long-term monitoring.
Anybody have any other statement you want to make out here? Yes.
Yeah, if you have a patient that having abnormal pap smear, that SIN3, it's for you, for the rectal, and is it typification 16 positive and 18, and how long you follow that patient by the exam, or yearly, every 2 years, if she's having continuously having abnormal pap smear from the rectal?
So I guess I lost the train of the question because I thought you were talking about CIN at first.
If you have a patient, if you have a patient having abnormal pap smears, like
abnormal anal pap smear, or cervical?
No, cervical.
Okay.
And continues having like abnormal SIN3.
Yep.
And the typification is 16.
I see.
And
you're asking when should we do an anal screening in a
yeah.
woman who's got a high grade? I would say any woman who's got a SIN3 should be considered for an anal pap smear, but particularly if she's either 16 positive or has 2 SIN3s in a row. You know, again, there's no hard data supporting that, but I think there are data showing that those women are at increased risk. And so the woman at a minimum should have a digital anorectal exam to exclude a prevalent cancer and should be considered for an anal pap.
I've known Dr. Grosbeck Parham for, I don't know, only 10 or 12 years, Grosbeck, but you, yeah, here's a man who dedicated the early part of his medical career to taking care of women in need, poor women in this country, and then decided that the huge need was in Africa, huge need here, but a much bigger need in Africa, and who went there to work under what I'm sure are difficult conditions compared to here. And I just want to say what, you know, there are a lot of heroes in this room, but the Dalai Lama gives an award to 50 unsung heroes every year or every few years, and I certainly think that you should be one of them. And I just want to say that to you for what you're doing there. You're trying to really break ground in saving thousands and hundreds of thousands of lives in Africa. So I think we should give you the acknowledgement for that. And Margaret Stanley and I were going to close the clinical workshop down with just sort of an ending little thank you for being here. But thank you for particularly all of those that have stayed the course to the end of this. But then we added on tomorrow, after we had put on this little closing time for closing this down, and there actually is more clinical workshop tomorrow, which, as you know, are really discussion of guidelines and a lot of the screening issues of screening guidelines. We're trying to do it all around the world, and so I hope that you all can make this tomorrow, and I appreciate you being here till late today. Thank you, Nubia, for being the chair of this session.
Hey, Joe.